Lakhani, and Dr. Vijay Shah will tell few words. And Lakhani, I want to know why it's not introduced in US and other things you will be explained. Okay, thank you.
Dr. Om Lakhani is a consultant endocrinologist from Zydus Ahmedabad, and he is a winner of many awards and a regular speaker at most of the conferences. And I had an opportunity to listen him quite a few times, and he was always the very best. And I believe he will counter very brave and intelligent disposition by Dr. Meenal, equally bravely and equally intelligently. The stage is yours, Dr. Lakhani.
I think before Om starts, I should say Mrinal, excellent presentation, and we're looking to a big fight, Om. We have big expectations.
Thank you, Mithun. Thank you so much, and good to see you here.
Thanks, Mithun. So I'll just start by sharing my screen. Is the screen visible?
Yes.
Okay, thank you. So, thank you for this opportunity. And what I'm going to talk about is which sulfonylurea is better, Glimepiride versus Gliclazide. And we already had the talk on Glimepiride aspect of it. Let's now talk about Gliclazide aspect of the same. Now, let me start first with the last point which Dr. Meenal raised. That was about the market share. Okay, if we were to determine the quality of any product based purely on market share, I think someday we'll have to decide that Maruti Alto is the best car in our country, which is not, right. The largest market share for any product is a combination of the cost effectiveness of the product and the affordability, and also of course quality, value for money, and so on, right. But at the end of the day, in any country, in fact, the market share of a cheaper car like Maruti Alto, especially in India, would be much lower than that of a Mercedes, which I'm sure each of you will agree with me that Maruti Alto is not better than Mercedes, right? So that's for sure. Okay, so let's debate this by talking about the various aspects of the thing. Let's first start with efficacy. Okay, so in any product, I think I'm surprised that efficacy was not a topic which was raised vehemently, because that is one of the major criticisms that Gliclazide is not effective enough, and that is what has been told. But let me just burst this myth. That is actually not true. You can see from this study from Meloni, where you had 121,000 patients. Okay, not a small number, huge number of patients, where you had these three drugs compared: Gliclazide, Glimepiride, and Vildagliptin, as an add-on to metformin. And clearly, you can see from here that the HbA1c reduction was higher in Gliclazide compared to the other two agents, right? Again, if you see the effectiveness in terms of the same study, HbA1c reduction, as you see as the time progresses, the HbA1c reduction by week 27 is similar in both the groups, Glimepiride versus Gliclazide, and the fasting blood glucose reduction is also very, very similar. And what you also, Dr. Meenal talked about is the rapid onset of action. Again, if you see fasting plasma glucose reduction with Gliclazide, within 15 days, you have the fasting glucose reducing in a baseline HbA1c of about 8.5 to 49 milligram per deciliter. And by day 60, it was as much as 87 milligram per deciliter. That is the magic of Gliclazide. So Gliclazide is, I think we can establish that it's a very, very efficacious molecule. Then let's talk about what we all worry about, and that is safety of a molecule, right? And how safe and durable is Gliclazide compared to Glimepiride, right? Here I'll counter a lot of points which Dr. Meenal raised. Unfortunately, she told me that it has less hypo and it has less weight gain, and she showed me studies compared with glibenclamide and not with Gliclazide, right? I mean, I know that Glimepiride has less hypoglycemia and less weight gain compared to glibenclamide. I think that's a very well taken. I think the debate is not between glibenclamide and Glimepiride. Any day I would agree that Glimepiride is a better drug than glibenclamide. And I'm sure you'll also agree that Gliclazide is better than Glimepiride, right? That's the point. Okay. So talk about hypoglycemia. I'll talk about data and I'll talk about theory. So first is the data. And, thank you, Dr. Meenal, for pointing out to the study that is a guide study. And just to tell you, you can see the reference below. Guide study is actually published. So, if you want, I can send you the full text of the article, right? It's a published study now. And you can see 50% less reduction of hypoglycemia compared to with Gliclazide compared to Glimepiride. And 50% is not less, right? You can make all criticisms for the study, but all you can say is that how do you defend 50% less reduction in 50% higher risk of hypoglycemia with Glimepiride, right? Even if it's a completely flawed study, even then this data is enormous, to say the least. And let me tell you, this data is not a fallacious data, because we see this in clinical practice, and I'll show you from a practical case scenario why Gliclazide is clearly better than Glimepiride, in a real life situation. So this is again, and remember, this is blood glucose less than 54, so it's actually severe hypoglycemia episodes compared to just a mild incidental hypoglycemia, and you can clearly see the difference is quite remarkable. So that is again very clear to say. But also, I would really like to point to your this table where you can see the hypoglycemia across the day, right? It's not just hypoglycemia during a momentary period of time. Hypoglycemia throughout the day is less with Glimepiride, with Gliclazide compared to Glimepiride. And you can see, especially in the afternoon, right? You can see, the hypoglycemia. Look at the hypoglycemia risk at 12 a.m. in the night, right? Huge nocturnal hypoglycemia which goes unrecognized. 5 p.m. in the evening. Look at the difference, right? So you can clearly see the difference is staggering. 11 a.m. in the morning, so on and so forth. I think there are a lot of things to really show that the hypoglycemia risk is clearly less with Gliclazide compared to Glimepiride. But there is a reason for it. There are theories for it. There are three theories rather, to say why Gliclazide has less hypoglycemia. One is that Gliclazide is, especially the MR form, is gradually released compared to Glimepiride and Glibenclamide. So the peak plasma levels are achieved 6 to 12 hours with Gliclazide compared to Glimepiride, which is just 2 to 3 hours after the dosing. And you can see from this chart here, I've circled the relevant points, right? So you can see Glibenclamide, the peak levels after 2 to 4 hours, and Glimepiride after 2 to 3 hours, whereas Gliclazide, the peak levels are reached after 6 to 12 hours. So it is a gradual onset of action. Hence, everything is dumped into the system, and hence you have, whereas the duration of action is similar with Glibenclamide, Glimepiride, and Gliclazide, which is all more than 24 hours, right? The second difference is presence of active metabolites, and you have Glibenclamide and Glimepiride, which has active molecules, whereas Gliclazide does not have an active metabolite, and because it doesn't have an active metabolite in circulation, the risk of pertinent hypoglycemia remains. And again, I think somebody told me that the only third generation sulfonylurea is Glimepiride. I think I'll just kind of bring to your notice that Gliclazide modified release is also a third generation sulfonylurea, right? Just to sort of, and I can clearly see from this table, taking from a very huge review on sulfonylureas published in 2020. So like I said, Gliclazide has no active metabolite in the circulation, while Glimepiride and Glibenclamide both have active metabolites in the circulation. What about another mechanism, and that is using EPAC2, right? Now, interestingly, when a sulfonylurea, it is supposed to bind with SUR1, but a lot of sulfonylureas also bind with another sulfonylurea-like receptor, which is EPAC2, both of which actually continue to stimulate the pancreatic beta cell to produce insulin. Gliclazide is the only sulfonylurea that does not bind with EPAC2, it just binds with SUR1. And because of this reason, Gliclazide, if you do develop hypoglycemia, you recover from hypoglycemia much earlier, because the EPAC2 binding is irreversible and remains for a longer period of time. So you would have I've seen a lot of patients in emergency. None of these are my patients, and then of course in future they become my patients because they were given Glimepiride and they develop hypoglycemia which remains for 2 to 3 days, right? They have to be admitted. They have to be, they have to remain under a continuous care, especially elderly group of patients, especially those with compromised renal function, and they are given high doses of Glimepiride, unusual doses of Glimepiride, and patient comes in emergency with hypoglycemia, and I wonder how many of them don't even reach the hospital, right? That's the sad part. I'm so frustrated with the hypoglycemias that we see in our emergencies because of Glimepiride with inadvertent use of that, and I think that's really wrong. What about weight gain? Advanced trial, right, showed that there was overall negligible weight gain in the trial. Over a period of 5 years, there was just 0.1 kg weight gain, which is, I think, quite remarkable for any drug, to say, not just a sulfonylurea. And the guide trial, which you sort of alluded to quite a few times, the body weight change was 83 to 83.1 to 83.6. and in Gliclazide group, whereas it was 83.7 to almost 1 kg weight gain in a Glimepiride group. So there was, definitely more weight gain. What about durability of action, right? And we all talk about, how long a product will last. And we know German engineering, right? European engineering, things are built to last longer. French engineering, you know this, and this all comes from, all these things comes in benefit here. The data clearly shows in advanced trial, this is remarkable. 4 out of 5 patients on Gliclazide attained their HbA1c of less than 7 and maintained that over a period of 5 years. Right, for 5 years they maintained the same HbA1c. That is the duration of the trial clearly. And there is a reason for this. This is actually comes from a study. You can read this again. There is free radical scavenging activity of sulfonylureas, and mainly this is seen with Gliclazide and not with other SUs. So basically, Gliclazide has, as a biaptyl ring, which is antioxidant in nature, and we know that the beta cell depletion that occurs as a progressive result of over a period of time is because of reactive oxygen species, and that is actually curtailed by Gliclazide. And again, in clinical practice also, we have seen that Gliclazide durability of action remains quite remarkable. So this is about safety. Let's talk about the renal benefits, I think, which Dr. Meenal did not even talk about. The advanced trial actually showed that over a period of time there was actually reduction in the microalbuminuria and progression to end-stage kidney disease. This is, remember, this comes before you had the recent SGLT2 molecule. So before SGLT2, now we all talk about renal benefits of SGLT2. What we forget that we already had a drug which is Gliclazide, which in a dedicated clinical trial showed that there was reduced cumulative incidence of end-stage kidney disease. And you can see in all parameters, new onset of macroalbuminuria, there was reduction. New onset of microalbuminuria reduction, and there's new onset of nephropathy. Again, there was almost reduction there. So what I can tell you is that, and the number needed to treat is also not bad, 1 in 41, right, which is not bad at all. So what it tells us is that Gliclazide is one sulfonylurea which prevents the progression of kidney disease. And on the other hand, when I want to use a drug which is safe in patient with kidney failure, sulfonylureas like glibenclamide and glimepiride have active metabolites. These are all taken from some review article. Right, you need to avoid glibenclamide in those patients with GFR less than 60 very clearly. Glimepiride needs a dose reduction, especially when you're going to GFR less than 60 or 30. Glipizide and Gliclazide can be used without dose modification between 30 to 60, and GFR less than 30, you can continue to use it with careful monitoring and dose reduction if necessary. So this is overall about renal safety. Let's come to the most important aspect, that is the cardiovascular safety. I'm very surprised Dr. Meenal does not realize that ADVANCE was actually a CV safety study for Gliclazide. There is no dedicated CV safety trial for Glimepiride. All the trials you have is retrospective. The Carolina trial was done for linagliptin. It was not done for Glimepiride, right? It's a comparative between a DPP4 and a sulfonylurea Glimepiride. It is not a dedicated trial for Glimepiride alone. ADVANCE, on the other hand, is a dedicated clinical trial for a CV safety trial, though it does not say CV safety, it says intensive glycemic lowering, which of course is a CV safety trial. This is what, before the rosiglitazone controversy, this is what it was typically called, right? And remember, ADVANCE, in any CV safety, including your SGLT2 inhibitors, there will be use of other agents, right? Other agents are going to be used in both the arms, right? You need to achieve a good glycemic control. You need to achieve a glycemic equipoise. Right, even in your EMPIRIC trials, other agents were used, right? Even in your DEPA-CKD, even in your DEPA-TIMI or whatever study you want, any major leader trial, whatever trial you want, sustained trial, all these trials also use other agents in both the arms, right? That does not mean anything. Ultimately it means that you need to achieve glycemic equipoise in both the groups, right? That's not an argument at all. But I'll give you one very strong argument, right? Textbook, right? And we all read textbooks. We learn from textbooks, right? This is the most, respected textbook in cardiology, the Braunwald, textbook of cardiovascular medicine. I'll just read out what it says in the last line. Statistically significant increased odds after multivariate analysis were associated with all sulfonylureas analyzed compared to metformin, including pancreatic-specific Glimepiride, except for Gliclazide, which had no associated mortality signal. Boss, Braunwald is saying Gliclazide is the only one which does not have a mortality signal. I think this is very, very, alarming to say, we are still continuing to use, this study. And this right, is a recent study published by Zhu et al. In Lancet, respected journal in 2020. Right? This is actually a meta-analysis of various sulfonylureas, and you can. I don't want to show you anything. You can just see from this slide. Right? The risk of stroke, you can say, is increased in patients with glimepiride. I can clearly understand hypoglycemia is more, 50% more, right? Severe hypoglycemia. The risk of MACE is increased, risk of myocardial infarction is increased with glimepiride, whereas it is reduced with gliclazide. I think this difference is quite very clear. In a meta-analysis of 232, 67 studies, reviewed, and you can clearly see the difference is quite alarming. I think there's no doubt, and anybody you ask, it's very clear that gliclazide is definitely the better drug for cardiovascular safety, and there is a reason for it. There is a reason for it, right? Remember, we talked about ischemic preconditioning. The impairment of ischemic preconditioning occurs because the sulfonylurea bind to SUR1, which is there in the pancreas, and it binds to SUR2A, which is there in the heart, and SUR2B, which is there in the smooth muscles, right? Now, what happens with SUR2A is that when you activate SUR2A in the heart, that impairs the ischemic preconditioning, and that is the ischemic recovery, which is there. And just I want to show you this chart, right? Again, I want to show you this table. The ratio of what you see in the extreme right, the ratio of SUR1 to SUR2A specificity. Just look at it, right? In gliclazide, it is 16,000. So it is SUR1 specific 16,000 over SUR2A. Whereas if you take glibenclamide, it is 6.4 and glimepiride is 1.35. So the specificity of SUR1 to 2A is clearly less. With glimepiride, it is 16,000 less. There is no reason to understand, definitely glimepiride is going to have cardiovascular risk, right? Nobody is going to do a dedicated CV trial with glimepiride alone in this era. But if it is there, I'm sure glimepiride will be out of the market. That 40% market share will clearly go away. There is a signal. There is a risk signal, right? We need to be aware of this, and we need to, consider this when we use it in our day-to-day practice. I'll show you some practical benefits. And before that, I don't know if Dr. Meenal follows cricket, but I think these two twins are very famous, right? This pair of twins is very famous. This is Stevo on the left and Marco on the right. Why I'm bringing this point? Because, Stevo and Marco, when they started their career in a very similar way. Both were very talented batsmen, and in fact, all-rounders to say the least, for Australia. In fact, for a lot of time, everybody knew that Marco, including Stevo, knew that Marco, his twin brother, was a more talented batsman, right? He was considered in the line of Brian Lara and Sachin Tendulkar at that point of time. However, who had a longer career, who scored more runs in Test and One Day, who is considered a legend in cricket? Stevo and not Marco. Why? Because Stevo is a better team player, right? And he's a better person to deal with for the team. He plays for the team. He plays for Australia. Whereas Marco has always been told that he plays for himself, instead of playing for the team. And hence, whose career lasted longer. And, this is what happens with glimepiride. The problem with glimepiride is that when you add glimepiride as a part of a treatment regime, that's why, you yourself showed me that when the HbA1c in a guide study was higher, you had higher hypoglycemia. The reason is because when you add, in such cases, you add a sulfonylurea, you tend to have more hypos and hence tend to have more glycemic variability with glimepiride. That is what happens with glimepiride. Glimepiride is not a very good agent to add as a part of a team, right? Whenever you intensify the treatment on a patient already on glimepiride, you tend to develop hypoglycemia. This has been seen in a lot of CGMs, in our own clinics and elsewhere as well. And the titration of glimepiride is also complicated. Every time you titrate, there are some people who respond more to glimepiride and hence end up with more hypoglycemia. And I'll show you some real life cases of how easy it is to titrate. This is a young patient who presented to us with diabetes. He was on glimepiride 3 milligram with metformin 1.5 gram. His HbA1c, you can see, despite this, he was of course obese and all. His HbA1c was still 8.4. Young patient, 32-year-old. The other parameters also you can clearly see. He was also intolerant to metformin, so this is a thing. And what we did was we started him on gliclazide, SGLT2, and so on and so forth. And what we did was we titrated his gliclazide. So you can see he started with 180, fasting sugar, and then we increased to 1.5, and you can see by end of almost 15-16 days, his fasting sugar went down to 135. After doing this, right, we did something very interesting. After doing this, we put a CGM in this patient, and this is this patient's CGM after the fasting sugar was fixed with a titrated dose of gliclazide, and you can see 119 is his average sugar, beautiful 96% time in range. This is a patient with HbA1c of 8.4, right? Who comes, and this patient now on follow-up, I'm sure will have an HbA1c. Of course, this follow-up 2-3 months has not been completed, but I'm sure his HbA1c will clearly be less than 7 very easily, right? So this is the practical use of it. And most importantly, right, we talked about why it is not there in America. I don't care. I don't care why a drug is not there in America. There are many drugs which are not there in America. There are many people who are not there in America, right? United States is not a benchmark for anything. If you want a benchmark for safety, follow Europe, not United States, right? United States is always influenced by money. It is less influenced by people's safety, right? But if you talk about guidelines across the country, and you can just check this up on, right? I'm not putting those guidelines there. You can just check this. Every single guideline outside an American guideline, Indian guideline, Canadian guideline, European guideline, British guideline, all of these guidelines have the preferred sulfonylurea as Gliclazide because of all these benefits we saw. That is the benefit in terms of cardiovascular risk reduction, which cardiovascular safety, which we clearly saw over Glimepiride, less hypoglycemia, 50% less hypoglycemia, less weight gain, better titrability, and better long-term durability. All these factors make Gliclazide definitely a better sulfonylurea. And it's, I think in today's world, the only sulfonylurea which is worth continuing to use because of the various benefits it has. And I'll just point out before we go into rebuttal also, Dr. Meenal showed us a lot of studies about atherosclerosis and inflammation. Just look at those papers. All of these are animal studies. All of them are animal studies. And if you want animal studies on Gliclazide, I have hundreds of animal studies on Gliclazide which prove everything, that it is probably, Jesus resurrected, you would say, in today's world, right? That is the thing, right? So I think end of the day, we have to move out of those animal studies in the labs and move out to clinical practice. And in clinical practice, tell me one study where Glimepiride has been shown to reduce cardiovascular risk, right, to the level which Gliclazide is probably, there. And so with this, I'll conclude, right, and I'll go on to the next stage.